Hi, everyone. Brian Lewis here from KidneyCAN. Thank you for joining us this afternoon for another in our three-part series on kidney cancer. Today, we're going to be discussing taking control of your kidney cancer. And I'm pleased to be joined by two colleagues and experts. One, a patient advocate in Florida, Megan Conley. Megan, go ahead.
Thank you, Brian, for having me.
Great, great. And I'm also joined by an esteemed colleague in Dallas at the University of Texas Southwestern, a medical oncologist, Dr. Hans Hammers. Hans?
Thank you, Brian, for having me.
Well, great. I'm going to start today's session by just talking a little bit about myself, and then I'm going to pass it over to the experts here. But, you know, we're talking about taking control. And I refer in my own diagnosis in 2007 as a time of right after hearing that dreadful news of what I call the white noise period. And so for the next several days, and I would even go maybe several weeks, there was a lot of noise going on around me. I've got cancer, but I didn't really understand what it meant and how it impacted me. And so now we have folks, and there's a lot of new concepts that we're going to talk about around shared decision making and building your team. And so I wanted Megan to give us a little bit of insight onto her experience. So Megan, do you mind sharing with us?
Sure. So in January of this year, at 34 years old, I was incidentally diagnosed with chromophobe renal cell carcinoma. But my journey really began in November of last year when I was undergoing a series of scans for fertility issues. I had experienced an ectopic pregnancy and subsequently was diagnosed with fibroids and endometriosis. And so during that process, my GYN surgeon had ordered me to have a series of ultrasounds and a pelvic MRI. And somehow during that process, the radiologist saw something in my kidney and decided to add an abdominal ultrasound to my orders, which wasn't initially ordered. And during that scan, she identified what she believed to be a 4.2 centimeter mass, referred to as an angiomyolipoma, which is a common benign mass of the kidney. And so at this point, I hadn't seen a urologist, and you know, since this was an incidental finding and it was outside of the scope of my GYN surgeon, and based on the radiology report, initially I didn't think it was something I needed to be overly concerned with, but I knew it was important to educate myself. And so I did a little research and I went onto the Google machine, and there wasn't a lot of literature out there, but there was some articles discussing the risk of masses in the kidney rupturing once they get over 4 centimeters. And there were also some studies that suggested that pregnancy hormones could contribute to the growth of AMLs. And so thinking that our focus was going to be on getting pregnant, I was concerned about the mass rupturing. And so I made an appointment with a urologist, and I met with him, and you know, since I was young, healthy, and asymptomatic, and I didn't fit the clinical profile of a kidney cancer patient, he didn't really see any reason to believe that it was anything but an AML, but suggested that we get a CT scan because he understood my rupture concern. So on Christmas Eve, I had a CT scan, and the results came back about a week later, and it was identified as a cyst. So since that was different from the initial findings, he suggested that I have an MRI done. And so I had an MRI done in January, and the mass was identified as either a papillary renal cell carcinoma or a translocation tumor. So at that point, I was left with a sliding scale of what if scenarios based on, you know, that diagnosis. And so I asked about getting a biopsy, and the urologist said, don't bother with it. There's always a risk of getting a false negative. You're young, so let's just proceed with getting surgery. And so at this point, I think I really learned the importance that you really are your own health advocate. And as a patient, you're the driver of the decisions that affect your health, and information is power, and it's really important to do your research and educate yourself on your diagnosis. And you know, I think because I was young, healthy, and asymptomatic, you know, and even for other patients, like sometimes you really need to push your primary doctor to refer you to a specialist, and sometimes you need to push the specialist to do more tests. And it's important to not be afraid to be proactive and ask for more questions. And I'll stop there.
Okay, well, thank you for sharing that story. I'm sure everybody listening appreciates that. Dr. Hammers, you get to talk to people from all walks of life in Dallas and from all over the country, probably all over the world, that come in to see you. Tell us a little bit about who you see and how that you help them in taking control of their kidney cancer.
Sure. So I'm a medical oncologist, and so I tend to see patients who have recurrent kidney cancer, stage 4 disease, which is a different group than patients with early stage small renal masses, for example, or patients who are at very high risk for recurrence. When I see patients for the first time, they often come in with the diagnosis. They often have read up on it, but I would say the comfort level with the data and the amount of data or the education that they had is quite variable. And so my job really is, in the first hour that I spend with new patients, is actually to educate them really of where are they, what is their disease, what are some of the features of their disease, and what are the options at that time. And often we may come up with a menu of things that can be done or several different options, and then we try to tease out together what might be the appropriate option at the time. I would say for most patients also, and I think this is quite illustrative for Megan's case, patients actually have the time in most cases to get additional opinions. And I'm a firm believer in second opinions. So I give a lot of second opinions, but patients who come to me as the first oncologist, so to say, I have zero problem. In fact, I sometimes encourage actually second opinions. Go to one of the colleagues that we know at major centers. That creates comfort. Patients are educated. Sometimes clinical trials may be available in certain places and not others. So it's just a better way in 2020 to engage with patients.
Great. Thank you, Dr. Hammers. So I'm hearing the phrase educate yourself and in this taking control. Megan, can you talk a little bit about the people that if you had surrounding you to help you through this process, and talk a little bit about the team that you may have assembled?
Sure. So, definitely it's important to have a strong support system, when you're dealing with a cancer diagnosis. My husband obviously was first and foremost there, during this process, but also family and really close friends. And, I had to travel to DC to get a second opinion. And, I had two really great friends there that, picked me up and took me to doctor's appointments and waited for me. And it really meant a lot.
So thank you, Dr. Hammers. I'm going to tie this in a little bit. So we've got this education component. We're assembling a team. Can you tell us a little bit about the team at the University of Texas Southwestern in Dallas, as well as how that team with the patient goes about making decisions?
Sure. Let me first comment on one thing that Megan said, or the gist of some of what she said. It's really, it's for me as a medical oncologist, it's so important to see what is the social support system that the patient has. Because let's say the first time you see an expert and you try to get advice, you will hear just 50% of what I'm saying. It's a stressful situation. You will not hear everything that I'm saying. So it's really, really helpful to have an extra pair of eyes, ears, etc. In fact, I encourage family to be there, as many as want, and then to also ask questions, write down questions, ask questions, etc. So that's really important. So in my role, as a medical oncologist, I very often have to work with other experts, and there's lots of overlap where I, for example, work together with urologists, radiation oncologists, other surgeons, for example. So it's a very multidisciplinary approach, and I would say it gets even more multidisciplinary as we get newer combinations and treatments, etc. So my job is to educate the patient, develop a treatment plan, and get the patient access to the resources, sometimes also for additional educational need. So for example, we're talking about radiation versus surgery for certain situations. I send them to both, let them talk to both experts, and then we come back and have some shared decision making. Also I would say sometimes patients want to be in contact with other patients who have gone through something similar. So many institutions will have patient support groups. There are also online patient support groups, one that's quite busy with kidney cancer patients, smart patients, for example. So there are many different ways to get educated, contact peers, exchange experiences. So it's a very important tool these days.
So you've noted, Megan, you noted earlier that you went to Google. I think 99% probably of those who are diagnosed that have access to a computer are going to do that same thing. And I think it's fraught with a lot of challenges and difficulties. Maybe you can just comment about what turned you from that to trying to gather other information.
Sure. So, I mean, Google obviously is probably everyone's first source of information. But one thing I found that was really helpful was speaking to other kidney cancer patients. And Dr. Hammers mentioned Smart Patients, which is a great resource for patients. There's also a lot of social media threads in different groups that you can join and ask questions. But I do caution people about those groups because you need to use them carefully because it can cause you more anxiety, and you have to realize that everyone's situation is different. So really, I found connecting with other kidney cancer patients directly was most helpful.
Great, thank you, Megan. And Dr. Hammers, do you have tools at your disposal in addition to referring folks to say things like patient support groups or smart patients? Does the hospital have other tools or the community?
We have, let's say, there's certain booklets you can sometimes offer, for example, that have been written about kidney cancer at different stages. We have the support groups themselves. I mean, in my experience, I would say, the job of us is to provide kind of like a skeleton or the landscape, if you will, right? So that patients actually understand when they go on Google. The first question that I ask is, have you Googled anything? Or if you haven't Googled anything, has your spouse Googled anything, or your children, etc.? And then I get a sense of, what do they know? What are their perceived impressions, etc.? And then I try to, really try to position things that they make sense for the patient. And then it's actually easier for them to go back out and fill in some of the gaps in these platforms, social media, or in other things. So I do think it's important for, somebody who can oversee it and put it all together to give kind of like this backdrop, if you will, the landscape, and that's going to be helpful typically.
So I want to touch on something that it was my experience, and maybe it's some other folks, but the landscape has changed over the last number of years, which is this concept of, I always approach the doctor as the expert, and what they say is the gospel, and I'll take what they say and go with it. The shared decision model changes that somewhat in that, of course, the medical providers are still the experts, but they try to, I guess, pass around some of the decision process to multiple voices. Can you comment on that and where you introduce that concept to a patient?
Well, I mean, so it's not like that I say you're coming in my office, this room we will do shared decision making. I would say it's just like the approach in 2020 is to provide information and lay out options, and then see what is for the patient probably the right thing or my recommendation at that time. And everything will have advantages and disadvantages. There are sometimes situations where I let the patient choose. There are certain situations where the patient has 4 or 5 different options, and it may really depending on the patient's personality. Where are they in their social life? What's the support system? How far are they from the center, for example? So there are many different variables that play into what's the best thing for the patient at the time, what's the best tailored thing. So it varies quite a bit. And so I don't say, okay, let's do shared decision making. The way it's pretty more I live it in the sense of like, okay, this is what I can tell you about your cancer. These are the options as I can see them, but you're free. I recommend some of the second opinions. See the specialists. Come back after you talk to them. What they offer you. So to say, let's say if there's a certain overlap with surgery or with radiation, for example, and then we try to come to something that might be the best fit. I do encourage patients to ask questions, absolutely, and they should never hold back questions. In fact, I welcome questions. And it really depends also on the patient sometimes, for example. So there are some patients who have quite some treatment history they're now really experts at their disease, and they come with very specific questions to me. So if somebody come in, let's say I know they had several lines of therapy, or maybe like with smart patients or something like that, they come to me, I actually just sit back and say, hey, what are your questions? How can I help you? And how can I answer some of those needs? So it's really, you know, where is the patient at the time? How can I help you? But I do encourage patients to ask questions. Absolutely.
Got it. So Megan, you mentioned earlier that something to the effect of you have to become your own health advocate. And I think you touched on earlier that you went for a second opinion in DC. Can you walk us through that process? Because that shows, I mean, the way you use the medical terminology so well, I know you've taken control of your situation. So maybe you can help people understand what you did through that process to take control.
Yeah, well, I think a lot of it just has to do with instinct too. I mean, just my conversation with my first urologist in Florida, I didn't necessarily question the diagnosis at the time, but I did question the treatment plan. I felt like the decision was not necessarily being tailored to me. So after I received the call, I took that weekend to really process everything and do some research. And I came across an article on the Cleveland Clinic's website about a girl that was close to my age, and she was diagnosed with kidney cancer when she was pregnant. And the takeaway I took from her article was really to take a step back and don't rush decisions. And so I thought about that article, and although taking time, you know, to get a second opinion, it delayed my treatment. And it took a little bit of effort and logistics. And it certainly went against every force in my body that wanted the cancer out yesterday, but I knew it was the right thing to do. And when you think about it, you know, we shop around and we get multiple quotes and estimates for a lot of things in our life, and our health shouldn't be any different. And you never have to go with the doctor that diagnosed you. And if you have time to safely get a second opinion, you should do that. And because I went to DC, and saw another urologist, his approach was entirely different from my first urologist. And he said, no, I do want you to get a biopsy. There's not a risk of a false negative. The pathology report is going to come back as either benign, undetermined, or cancer. The latter two do require surgery. He said, I want you to get a biopsy for two reasons. One, you're young. There's a 5 to 10% chance that this is the fat poor angiomyolipoma, which can be commonly misdiagnosed as cancer based on imaging alone, which I learned imaging alone is not diagnostic. And then two, he said, if it is cancer, I want to know exactly what we're dealing with before I get in there. And, you know, that may change my treatment plan, deciding whether or not I would attempt a partial nephrectomy or radical.
Yeah, and that's a great point. And Dr. Hammers, this is not disparaging to your profession at all, but one doctor of mine at the NIH said, Brian, remember this always. It's the practice of medicine that we're in, which means it's not perfected. And I agree fully. I think I think we have maybe some kind of a guilt complex going on that we shouldn't be questioning the expert, but I think also it's every patient's right to get as much information as possible. Great points there. Dr. Hammers, one of the things that helped me was this concept of while you're shocked through the diagnosis, this tumor didn't appear overnight. Could you comment on that in terms of taking your time going forward?
Yeah, so absolutely. So exactly. So cancers like that don't grow overnight. So if you have a 4, 5, 6, 7 centimeter tumors, you had those tumors for years. So the average kidney cancer, if it's a malignant kidney cancer, grows a little bit more than a centimeter per year in size. We know that from small renal masses, which we found now more. We actually do find now more commonly. So the frequent use of imaging studies for completely unrelated reasons. Now let's just find these small renal masses, which we sometimes just observe, etc. So we have growth curves for these particular tumors, and we do know they grow roughly a centimeter per year. So if you have an 8 centimeter tumors, it didn't happen overnight. It happened over several years. So you would typically, if you don't have symptoms, if you don't have much symptoms, then you really absolutely have time to do something. It's a different story if you are, leaking blood and your bladder was clotted from all the blood that you're leaking. That's a different story. Then you need a fairly rapid intervention, but that's a no-brainer. Typically, I would say, for most patients, even with stage 4 disease, the disease I focus on, meaning where the disease actually has spread, you should never ever feel that you're with the back against the wall. Most patients, the vast majority of patients, has time to get a second opinion. And I would say, in these days of coronavirus, I would say it is actually getting much easier, right? It used to be you had to fly to the doctor for that opinion, do it, et cetera, et cetera. We're doing now everything telehealth, right? It takes no time to make an appointment via telehealth. So I do think, I do hope that some of these changes that we experience in the healthcare delivery system will be changed forever in a way that it will be useful to patients who want to have a quick sign off, if you will. Hey, this is my scenario. Is this the right thing to do or not? To get a very quick second opinion without necessarily traveling across the country, et cetera, et cetera.
Got it. So in just a moment, we're going to have to go to questions. And for those folks who are listening in, feel free to send in your questions. I just want to touch on this for those folks who might be out there early on in their diagnosis. What would you tell someone, Megan, I'm going to go to you first, during that first week, if there's someone out there, first month that has been diagnosed? What would your advice be?
Sure. So, I think, and I mentioned it earlier, information is power, and kind of keeping with the theme of taking control. After I received my diagnosis, I thought a lot, and I kind of reflected on stoicism and Epictetus, and kind of being aware of what is and what is not in your control. And getting the type of cancer I was diagnosed with was not in my control, but how I handled my journey once I was equipped with the right information was in my control, and that was very empowering. And so that initial diagnosis and the different scans and MRIs, and there was a lot of uncertainty throughout that period, and that there was just a heavy weight on my shoulders and a lot of anxiety. And once I had my biopsy done and it was determined this is what you have, chromophobe renal cell carcinoma, in a weird way, I felt relief, because I didn't have to question anymore, like, what is this? I knew what it was, and I knew what needed to be done to get it taken care of. And so the more information you have, the easier this process can be. And it's not an easy process, but it is easier.
And Dr. Hammers, did you have anything to add there? Because you touched on this earlier, but any advice to those recently diagnosed that you see?
Yeah, so again, take a step back, get always a second opinion, period. You make so many, for everything that you buy, you look in the review section of your Google or whatever search, right? And so it's so important with something that is so upsetting and potentially life-threatening. It's so easy to get a second opinion. No physician minds a good second opinion. So it's really important. And especially, I would say, for diseases that are not so common, like kidney cancer, for example, is not the most common cancer, obviously. And so it's really important to get a good second opinion. Nobody minds, and it's really a very useful tool.
Got it. Well, we have a question here. I'm just going to read off, and let's see. Considering the current issue with the COVID-19 pandemic, do you have any recommendations for how to communicate effectively with your healthcare team via telemedicine or other means? Any thoughts on that, Dr. Hammers? You probably had your world turned upside down in terms of telemedicine in the last few months.
So the interesting thing is, despite us opening up, et cetera, for safety reasons, we've decided to still only see patients in person who really need to be seen in person. Patients who are coming in, for example, for therapy, we tend to see in person, et cetera. But I would say still 70% of my clinic visits right now are still actually virtual. And it can be done well. I can see patients, I get a clinical feel, I can do some examinations via the screen. I get lab work done, et cetera. There's really no reason to expose the patient at a higher let's say, exposure level and therefore coronavirus risk than necessary. So, and patients really appreciate it. They don't have to travel an hour or more to come in, etc. So I do think most healthcare systems are now really good at delivering good healthcare during these times. I think we have adapted, and I would say right now we're delivering the same level of care than before coronavirus.
Got it. And back to your point, Dr. Hammers, you said it's important, imperative that you have another set of eyes and ears listening in. Is that applicable to telemedicine, that you can have other folks on?
So absolutely. So in fact, what's really funny is sometimes when we started, like I had two new patients last week, where I only saw the patient, but I knew they were looking around the screen, and I knew there were other people there. So I asked them, why did you all sit in front of the camera? And there were all of a sudden 3 or 4 people. And it really encourages a conversation. And that's really what you want to have. You want other people to ask questions. Again, the patients are often shell-shocked, and it's very difficult for them to maybe ask even certain questions, etc. I'm always scared if I just see the patient, actually. Then I'm always worried, okay? Because then often the support system is meager, and that will always put the patient higher risk for worse outcome. So I actually appreciate it. The more people involved, the better. I'm not afraid of questions, and your physician is not typically afraid of any questions. And I love it when there is a social network that is supporting the patient and is helping in this initial shell shock phase to understand the question, the data, and to ask questions.
Megan, I just touch on you because we got a couple of questions coming up that are back to Dr. Hammers. You said you had your husband with you and some family and friends with you early on?
Early on, but my surgery was on March 31st in the midst of COVID. So my husband wasn't able to come into the hospital with me, and I was there for about a week. So I completely understand, Dr. Hammers' comments about the importance of having family members there, because I was in my hospital room for a week without family, and doctors were coming in and asking me questions, and I wasn't in the best state of mind with all the medications to really understand what was going on, and even just getting out of my bed to walk, which you should do after a partial nephrectomy. I couldn't do it, and so I had to get a walker but if you had a family member there, they would help you. So It was hard.
Sure. So Dr. Hammers, I got a question here. Heidi wants to know if clear cell renal cell carcinoma is hereditary. Her husband has it, and so did his father, but the surgeon doesn't think so. Any thoughts on that?
So that's a very good question. The vast majority of clear cell kidney cancers are sporadic. There is a small single-digit known entities of genetic syndromes within a family where they're hereditary, meaning there's a certain genetic defect within the germline of the patient, within the initial makeup of the patients, and in the family will be, often given one-to-one, so to say, to descendants. So there's a certain risk for certain disease. Often these are multiple tumors and often affecting both tumors. In this case, again, it's very important to get genetic counseling involved. So that's something that we offer as a standard. So the moment we have a positive family history, somebody, like Megan's age, right? You typically send those patients for genetic counseling because there's something unusual. The median age of diagnosis is in the 60s. And so we were always wondering, could there be some background, certain genes that make it more likely to get a certain cancer, for example. Oftentimes we don't find it. And so just because, let's say, we don't find anything in the father-son scenario here, does not mean there could be something that we may find out in 5 years from now that may increase the risk, for example. We just don't know about it yet. So it's really important to see a genetic counselor, talk with them through it, and maybe have some screening suggestions for offspring, for example, to take certain precautions. So it's a very good question, and often a bit more complex than I can explain on social media.
And Megan, bear with us. I got a couple more questions that are very medical oriented here. John wants to know how you might be able to know if you have kidney cancer during its early stages.
Oh, that is the problem. Okay, so you typically don't know. And for example, Megan was diagnosed really just because she had the workup done for a completely different reason, right? Is it her primary care physician's fault that didn't find it earlier? Typically not, because no physical exam typically finds these tumors. The kidney is in a bag of fat in the back of your body. If it's not like a huge mass, you don't get it on physical exam. You don't see it on the classic lab work. If by chance, let's say you get a urine, that you may sometimes see a little bit of blood in the urine, but there's really no great screening test right now for kidney cancer. I would say, if you don't have, let's say, a certain family history that would alert you that you want to screen family members more frequently, you typically don't get that done. So unfortunately, for early stage, there are no good clinical signs. But the interesting thing, again, is because of the frequent use of imaging studies, we now have a clear migration of stages to the earlier stages. So it used to be the internist tumor, where patients presented with a large palpable mass, blood in the urine, and pain in that particular area. And so that has clearly moved now to the phenomenon of what we call these small renal masses, little tumors that we don't know yet what they are, maybe just 1 centimeter, 2 centimeters, where we still wonder, okay, shall we just observe them? Shall we do a biopsy right away, et cetera, et cetera? So we do find them earlier, but we don't have good ways of knowing that you have an early mass, small mass.
All right, I'm going to try to squeeze in 2 more quick ones here. Holly's husband just was diagnosed with synchronous kidney cancer, which is very rare. Should he get a second opinion?
A second opinion, never a question. Always get a second opinion. Okay. Now synchronous is now. I don't know if she meant like tumors in both kidneys at the same time, or a mass and then she has disease somewhere else, or he has disease somewhere else. So that I don't know what she meant by that. But certainly independent. So always get a second opinion. It never hurts to get a second opinion. So I'm always fully supportive.
Great. And real quickly, Billy would like to know if immunotherapy is always necessary after the kidney is removed.
So that's a very good question. Actually, right now, the FDA actually does not have an FDA-approved immunotherapy regimen for patients who had the kidney tumor removed and who are, let's say, at high risk for recurrence. The recurrence risk is very variable, can range from 5% to 50 to 80%, depending on the stage and some of the features of the cancer. It's being tested, and phase 3 trials have fully accrued. And I would say over the next 3 to 5 years, we will find out if this approach works, if early immunotherapy for patients who have, let's say, a 30 to 50 to 80% chance of recurrence could potentially reduce the recurrence risk. So these are questions that are being tested right now. Right now, we do not have an immunotherapy approved in that space. So it's typically observation. And hopefully in a few years, we will have the answer. But that's another point I want to quickly make is clinical trials are so important, because they are really the tool for us to improve care, develop new therapies, etc. Often by getting a second opinion, let's say if you see a local oncologist, by getting a second opinion, going to a larger center, you may have the option now to potentially participate in clinical research, clinical trials. And I think that's always very much worth considering. You may actually expand your treatment options by going to a place that sees your cancer type more often.
So Megan, I want to start closing out with a question for you around patient engagement, which is a term that is being used more and more in this space. You've given us prime examples of engaging with your situation. Can you tell some of the folks out there, again, just remind them or give some feedback, give them hope about what you did to engage and taking control?
Yeah, well, I think it's recognizing that if you can't take control yourself, going back to surrounding yourself around friends and families that can help you take control, and whether that's doing research, helping find someone to get a second opinion with, deciphering medical terminology, that's all very important. And I think too, throughout this whole process, you're not only trying to navigate the medical side of it, but you're trying to deal with the emotional part. And I would say it's something that we haven't talked about today, and I know we're running short on time, but it's really important to be aware of your emotional health during this period. And that's not only going through treatment, but also including, remission and being cognizant of those emotions that you're feeling and finding ways to manage those anxious feelings that you're having. And that, that includes surrounding yourself with a solid support network and maybe having faith or connecting with other kidney cancer patients, keeping a journal, exercising, meditating, whatever it is, just to help keep yourself sane during this.
Yeah, well said, well said. So thank you for that. And I think you've given us a good idea for a future topic for one of these next Facebook Lives. Unfortunately, folks, we've run out of time today. We really appreciate you all tuning in. I just want to say this is part 2 of 3 in our series. Next up is survivorship. We'll be announcing that shortly. We have the ability to answer your questions on our Facebook pages. So if you didn't get a question answered, please send it in and we'll make sure to answer it on the Facebook pages in the next couple of days. Also want to say thank you to the National Kidney Foundation and KidneyCAN, the support team here, and also to the sponsors who underwrote this. Thank you. And most importantly, I want to say thank you, Megan, for sharing your story with everybody. Thank you very much.
Thank you, Brian.
And Dr. Hammer, it's always a pleasure. Thank you so much for sharing those insights and really appreciate it.
Thank you, Brian.
All right, everybody. Well, on that note, we wish you all